Okay, we're now live. Hi, Elliot Fishman here. It's June 26th. The end of the June is approaching. I guess Monday's still June 30th. I haven't been out except when I came to work this morning. It was warm, but not as bad as the last few days. Hope everybody is doing well, and hope everybody is about to get some time off, hopefully now or sometime in the summer, depending on what works. And I know academics, it's always hard. People are short-staffed, and now with everything with the visas, where a lot of the, a significant portion, particularly of residents and interns, come from outside the U.S., and with the J-1 visa issues, a lot of places are sweating, including places like Hopkins. When are the new interns and residents going to get here? But hopefully that'll all be straightened out sooner than later. Today's topic is the oncology patient, the acute abdomen. So we have spoken, and we all talk about the acute abdomen in every patient, right? So you think about acute abdominal pain, that's what the ER is, right? That's where CT really excels. And the acute abdomen can be appendicitis, it could be diverticulitis, it could be pancreatitis, it could be acute cholecystitis, inflammatory bowel disease, pelvic inflammatory disease, aortic dissection, aortic rupture, splenic infarction, splenic bleed. You name the organ, I could give you 5 pathologies. In the oncology patient, all of those differential diagnoses are still there, right? If you have a patient who's being treated with chemotherapy, they can still get diverticulitis or appendicitis or anything else. So when you're dealing with a patient who's an oncology patient, either recent surgery or current or recent chemotherapy or radiation therapy, all of the usual things we think about for acute abdomen need to be considered as well. But then we start thinking about other things. So since I mentioned radiation therapy, patients with radiation therapy these days, because of the better beam and better focus and better technology, it's not like the old days where everybody got radiation enteritis, but patients can get radiation enteritis. They can get adhesions and bowel obstruction. So patients getting radiation therapy, you can have injury to the kidneys or liver or spleen. Again, far less frequent, far less of an issue than it was 20 years ago, but it's something to consider. Patients with chemotherapy, depending what type of chemotherapy they could get enteritis, and it can be very severe enteritis due to chemotherapy. You can have involvement of the small bowel or large bowel, or both small bowel and large bowel. You can get impressive enteritis, potentially ischemia. You can go all the way to perforation. Patients with bone marrow transplants can get neutropenic processes, including neutropenic colitis or typhlitis, which is marked inflammation of the cecum in a patient who's neutropenic. But also you worry about graft versus host disease, where you get very significant bowel inflammation, narrowing of bowel, potentially bowel obstruction, and potentially bowel obstruction. Anything with chemotherapy can lead to all sorts of complications from the chemotherapy. And again, things like ischemia are more frequent. We look carefully at the vessels. Sometimes you can get vasculitis from certain therapies, and that can lead to an increased incidence as well of patients having a vasculitis or ischemia. We talk about things like immune therapies. Patients do have increased incidence of inflammatory bowel disease, increased incidence of proctitis. Patients also can have anemia, so the potential for bleeding in bowel or bleeding in the adrenal, renal, liver or spleen are all possibilities. We talk about patients who've had surgery. Surgery, in the early part, you talk about complications, leak and anastomoses, bleeds and anastomoses. In complicated surgeries like Whipple's, potential for aneurysms or pseudoaneurysms at the resection site. So all of the things that are specific to that surgery and disease process. Patients with surgery can get adhesions. Adhesions you think of months or years later, but it can happen in a week. So a patient with recent surgery, you have to worry about adhesions, you have to worry about bowel obstruction, you have to worry about hernia, you have to worry about bleed, you have to worry about pseudoaneurysm. Now CT is great because it can answer all of the questions, which explains why all of us are so busy taking care of these patients. Other things you think about, some of the different chemotherapies. There's a lot of different chemotherapies. Again, enteritis is a possibility. Injury to the kidneys, loss of renal function can be a problem with many of the different chemotherapies. The kidneys are sensitive. Combinations of chemotherapy and radiation therapy can cause potential issues. We talk about, in the oncology patient, a range of processes, okay? We think about patients developing acute cholecystitis as a complication. We talk about biliary tract dilatation or inflammation. We talk about pancreatitis as one of the complications of chemotherapy. So, in a sense, the point I'm trying to make is, and we wrote an article, Harshna and myself, Linda Chu, Satomi Kawamoto, just published literally within the last month, two-parter about complications related to related to therapy in the oncology patient. So it's a really good article to read. I'll put the references up on CTisus. It's in our monthly look at the different articles we think are worthwhile. So again, I think the message I want to give you is, when you're doing symptoms of the acute abdomen or suspicious acute abdomen in an oncology patient, think of all the things you think about in the non-oncology patient. Then think about the things that are specific to that patient as it relates to their treatment. Again, different processes can occur from surgery, different processes in patients who get chemotherapy, different processes from radiation therapy. And of course, many of our patients get all three of them, or at least two of them. Think about a Whipple's. Patients will typically have had chemotherapy, radiation therapy, and then surgery. So the complications, really can mount up. Early intervention, early management is critical on patients having good outcome. Quality studies, we like to do studies with water as an oral contrast agent and IV contrast. If you're thinking about bleeding or you're thinking about enteritis, I like dual phase imaging to get a good look at the mesenteric vessels, both on the arterial and venous side, and I like to look at enhancement changes, scan from diaphragm to symphysis, get a good look at all the big organs, the liver, the spleen, look at the adrenals, make sure there's no adrenal bleed, which can occur across many different chemotherapies or therapies. So you want to do all of those things, and you want to look at it very carefully: axial, coronal, sagittal, look at the mesenteric vessels, study the vessels, study the bowel, and look again, thinking about what the patient's therapy was, what might be specific for that patient. And again, immune therapies are one of the things that do have lots of complications, even when the patient is long done from the treatment and is doing very well. So I think I'll stop there. Again, read those articles. I think there's really good cases, there's really good information, and I think it would be very helpful for you. So with that, hope everybody is doing well, and hope to see you all soon. Catch you later.